and welcome to Chapter 19, Microbial Diseases of Skin and Wounds. In this lecture, I am going to focus on the diseases that you need to know for your take-home exams. So, what I would do is take notes and then follow along in the book if you can, and highlight the information or somehow tag the information that you will need for your exam. Here we go. So the first thing we need to do is review a little bit about the skin. You remember from anatomy and physiology that the skin has many functions, but mainly it is a barrier. It helps us from dehydrating, it helps regulate temperature, we touch, we feel, we can sense heat, cold, pressure, pain. It's very important, along with exposure to UV radiation from the sun, not a tanning bed, in the formation of vitamin D. And then, as we learned in our immunology studies, it is the first level of defense. It is a physical barrier and a chemical barrier to pathogens. Remember that skin consists of the dermis and the epidermis. The epidermis is what faces the environment. The dermis is underneath it, and below the dermis, then we have the hypodermis. Here's a nice picture. It looks a lot like the one from the anatomy and physiology book. I would ask you to take a look at the hair follicles. Notice that the oil glands are attached to the hair follicles. Take a look and see where the blood vessels are located, where the encapsulated nerve endings, your figure calls it a pressure receptor. Find the sweat gland. Then find what we call the naked nerves, and those are usually pain. Notice that these are all in the dermis. Remember that the epidermis is made up of stratified squamous epithelial cells, and the top 20 or so layers are dead epithelial cells that are filled with keratin. So we don't want anything to get past the skin. That causes major problems. So ask yourself this: why is the surface of the skin inhospitable for most microbes? Go back and think about our discussion on the first level of defense of the body. You might want to pause here and answer this question. Microbiota, little life. Not little as not very many, as in few, but as in small. There are hundreds, maybe even thousands of different kinds of microbiota on our skin. And their job is to protect us from the pathogens. And so they're very, very important in that they compete. They try to snarf up all the nutrients and take up space. They also produce the acid for the acid mantle on our skin. As you noticed in our hand washing experiments, that no matter how much you wash your hands, put on, some kind of alcohol solvent or whatever, it you're always going to have bacteria growing. And this is good. Of course, bacteria like moist, warm areas. And as we get older, the bacteria will break down the substances that come out of our sweat glands and make us very stinky. Isn't that wonderful? Thank you, bacteria, for making us stinky. We do have yeasty beasties living on us. We have all kinds of bacteria, probably some viruses that we haven't found yet. If you look at some of these, like Staphylococcus, you know that Staphylococcus can cause nasty diseases. But that's only if it gets through the epidermis and invades the dermis and the systemic circulatory system. So take time and answer this question. Why is the normal skin microbiome considered beneficial to a person? Once again, think about the immunologic implications. Think about the chemical implications. Take a minute to answer this question. Had enough time? Okay. So let's get down to business. Folliculitis. This is one of the diseases that you need to know for your exams. And when you look at your sheet of paper, you will notice that there are 7 categories that you must answer for each of the diseases. These I took from our pathophysiology class. You need to be able to define the disease, discuss its etiology, its origin, do a short discussion on the epidemiology, discuss the pathophysiology, in other words, how does it cause disease, list the clinical manifestations. These would be the signs and symptoms. What are preventions and what is the treatment for each disease? And then last, what is the prognosis for the patient who has the disease? And what's the most common outcome? So when we look here at folliculitis, and you notice that itis means inflammation, and folliculo is the follicle. So it means an inflammatory condition in the hair follicle, and this is usually due to an infection. Oftentimes we call this a pimple. If it occurs around the eyes, we call it a stye. If it spreads to the surrounding tissue, it's called a furuncle, and when you have a bunch of furuncles grow together, we call it a carbuncle, and it looks a lot like a nasty, nasty cyst. So most commonly, folliculitis is caused by Staphylococcus. Remember, Staphylococcus is a gram-positive cocci. It's arranged in grape-like clusters. And remember, it grew on MSA, mannitol salt agar, which means it can live in high salt content and it can avoid desiccation, which makes sense if it's living on your skin. Think about what sweat is and how that is can affect bacteria. Staphylococcus epidermidis is found on the epidermis, and Staphylococcus aureus, aureus means gold or golden, and oftentimes on nutrient agar it will have a yellowish appearance. Staphylococcus aureus is a pathogen. Staphylococcus aureus is a pathogen when it enters a wound. So what are some of the problems that we see with Staphylococcus? Well, if you look at this chart, table 19.1, and look at the virulence factors. In other words, these are the things that cause the pathogen to be virulent, the pathogen to cause a disease. And look at these enzymes. Coagulase will break down blood clots. Staphylokinase, lipase, beta-lactamase. Staph aureus has these factors that prevent macrophages from phagocytizing them. They have a little bit of a slime layer. They have what's called protein A, which is a protein that's on the surface of the coccus. And then they produce toxins. Cytolytic, which means it kills cells. Leukocidin, which means it kills white blood cells, mainly neutrophils. Epidermal cell differentiation inhibitor, which means it prevents the epidermis from becoming keratinized. Exfoliative toxin, which means it will cause the epidermis to separate from the dermis and fall off. And then toxic shock syndrome toxin. And we're going to look at toxic shock syndrome when we look at the reproductive system. Notice that Staph epi, doesn't have very many virulence factors. It rarely ever causes any disease. So, if Staphylococcus is transmitted by contact or by fomites, it can get through breaks in the skin. The infection can get to the blood, move to the organs in the body. This is not good because it will kill us. And as we said before, epi lacks virulence factors where aureus is found on our skin, in our mucous membranes. And as long as it stays outside, it's all right. But once it moves inside, it can be deadly. So some of the diseases, let's look at this. It's nice that they have the page numbers there. Scalded skin syndrome, impetigo, toxic shock, bacteremia. Bacteremia means bacteria in the blood. EMIA means in the blood. Endocarditis, this is not good. This is an inflammation of the endocardium. It can cause pneumonia. And we will talk quite a bit about Staphylococcus aureus when we talk about food poisoning. So basically, to diagnose this, we're going to take a sample of the pus and look at it on a slide and see if we can find gram-positive cocci. You can see there that infections are treated with drugs that are specific for gram-positive infections. Vancomycin, remember, is a broad-spectrum drug that kills a lot of different things, and so it can be utilized to treat strains that are resistant to the more common antibiotics. How do we prevent this? Well, wash your hands. And how about we wash our hands? How about we use hand sanitizer? How about we use proper hygiene? Wash your face, wash your neck. The biggest problem in hospitals is MRSA, methicillin-resistant Staphylococcus aureus, and it can be a killer. But if we use proper hygiene, then we don't infect our patients with a deadly disease. One of the saddest diseases caused by Staphylococcus aureus is called scalded skin syndrome. And we see this mainly in nurseries, at the hospital, at NICU, neonatal intensive care units, because someone carries a mutant strain of Staphylococcus and they don't know it. So basically what happens is that the Staphylococcus aureus strain gets transmitted to a newborn child. And since they don't have a very deep epidermis, it gets under the skin and forms blisters. And these blisters lift the epidermis up off the dermis, and the skin will peel off. It looks very similar to a snake shedding its skin. Because the dermis isn't affected, there's no scarring. It is painful. Death is extremely rare, but often death is due to a secondary infection, not to the Staphylococcus. Here's a picture of a newborn. You see in the lower right-hand corner an adult thumb holding the baby's foot, so you can see how tiny this baby is, and you can see that the epidermis is peeling off. So this is not a happy baby. The epidemiology occurs mainly in newborns. It's transmitted from one person to another. Basically, when the skin starts falling off, we all say, ooh, scalded skin syndrome. It can be treated with antibiotics. So it's hard to prevent, but basically we need to wash our hands, use hand sanitizer, and wear gloves in the neonatal unit and the neonatal intensive care units. Impetigo, also known as pyoderma, which pyo means pus, so pus in the skin, and erysipelas. Yeah. These aren't diseases you need to know. However, when we look at young children, you'll see this. Impetigo is a red patch that forms on the face and the limbs, and erysipelas is an infection that spreads to the lymph nodes. It's mainly caused by Staph aureus. It can be caused by Streptococcus pyogenes, and the virulence factors contribute to the severity of the disease. Hyaluronic acid is going to be a major component of helping the connective tissues stay together, and if that's broken down by enzymes, then we have problems with the tissues staying together. And then there are pyrogenic toxins. Pyrogenic, the formation of fever. Pyro, fever, gen, formation of, ick, pertaining to. So here's some impetigo on a child. We usually see them on children up to about 6 to 7 years old. Yuck. And then erysipelas, sometimes it's called slapped face disease, because it looks like someone slapped your face. Owie. All right. The big problem with either of these is that if the infection gets into the circulatory system, then it can wind up in the kidneys, and there it will infect the glomerula and the nephron, causing it to have an inflammatory response. This happens quickly, therefore it's acute. If not treated, are not caught in time, it results in kidney failure and death. When we look at the epidemiology, once again, it spreads person to person or via fomites. This is going to be a reoccurring theme, person to person or fomites. Diagnosis, mainly you see the little leaky pussy vesicles. Ugh. These can be prevented with hygiene and cleanliness. Acne. Acne is not on your list, but you're going to see a lot of it, and I thought we'd talk about it. Acne is caused by P. acnes. Yeah, you go ahead and say that P word. We'll just call it P. acnes. It's a gram-positive rod-shaped bacteria. It's commonly found on the skin. And basically what happens is that the pore of the oil gland that's attached to the hair follicle gets blocked. And it may be blocked with dirt, it may be blocked with just too much oil being on the skin. Then we see that the skin becomes inflamed, it swells over the pore, the bacteria invade the follicle, and then we have lots of bacteria chowing down on the oil, on the sebum. As the bacteria die, then a blackhead will start to form. And if it continues, then what we'll see is a severe inflammatory response that causes the formation of a pustule, which means a cyst of pus. And if it ruptures, it can produce cystic acne, which is severe acne. And since this is taking place in the dermis, then we can a patient can have quite a bit of scar tissue form. Of course, most of the time this is in the face, the neck, the chest, the back, and the shoulders. And we see an exacerbation of this during puberty. So it can occur any time in life, but usually with the onset of puberty, we see an increased production of sebum, especially with increased production of testosterone. So that's why we usually see it, the more severe type of acne in young males. We can treat this with all different kinds of things, antimicrobial drugs, something that causes this dead skin to exfoliate. It's what a lot of the scrubs do. Accutane is used to treat severe acne. And then sometimes UV light is used to destroy the bacteria. Problem with utilizing ultraviolet light is that, especially in those patients who have fair skin, they may develop melanoma later in life. Another disease you need to look at, but is not on your list, is Pseudomonas aeruginosa. Mainly, this is an opportunistic infection. We carry Pseudomonas aeruginosa in our nasal passages. It's in the dirt, it's in the air, it's everywhere. But once the skin is broken and Pseudomonas can enter into the circulatory system, then it can cause bacteremia, fever, chills, shock, and eventually it will kill the patient. Most of the time we see this in burn patients. The burn patients are going to have a green color to them. And so here is a badly burned young man, and you can see that most of his injuries are on the back and the neck. You can see the pustules behind his ear, along his neck, but what you notice is the green color on his bandages. And this is due to a Pseudomonas infection. So once again, it's opportunistic, and it usually will not cause problems in healthy people. People who are immune compromised may be more susceptible, but if you lose your covering, your skin, you can have many different severe infections. Okay. About the only way to treat this is to remove the burned skin, and this is called debridement or debridement. And basically that means you have to go in and physically peel off the burned skin. And then you can put topical antimicrobials. A lot of times IV antibiotics will be given as well as topical in order to attack the bacteria from both sides. Diagnosis can be difficult because we don't expect Pseudomonas to be a problem in healthy people, but Pseudomonas is a gram-negative, non-enteric, and it is tough to kill. It is resistant to many drugs. Later, we're going to talk about Clostridium species and how they can cause botulism, how they can cause food poisoning. But one thing you need to know about Clostridium, especially Clostridium perfringens, is that it will cause gas gangrene. You will see this in diabetic patients who are not taking care of themselves. They're not controlling their diabetes. And basically what happens is that as diabetes progresses, patients will develop neuropathy, which is disease of the neurons, mainly in the feet. And they won't be able to feel hot, cold, or pain. They can feel pressure, but usually not hot, cold, or pain. And so they'll be walking around barefoot, they'll stub their toe or step on something and get a wound. And they don't know that they have a wound because they can't feel it. And so they won't attend to that wound. They won't clean it, they won't put antibiotic on it, they won't put a Band-Aid on it, they won't take care of it because they have no clue that they have hurt themselves. Clostridium grows in the soil and it forms spores. What other bacteria have we worked with that forms spores? Give you a hint. It starts with a B. Yes, Bacillus. But Clostridium is anaerobic, so it cannot live in tissue that is oxygenated. So what happens is that it gets into the part of the wound where the tissue is dead, and its little spores get up in there, and it opens up, the spore opens up, the bacteria begins to multiply, replicate, reproduce, and as it does this, it releases toxins, and these toxins then are going to kill healthy tissue, so they have more food and they have more area to grow. Notice that there are 11 different toxins. So a vegetative cell is an actively growing cell. Remember that. So here's someone who has gas gangrene of their toes. You can see the blackened tissue is the dead tissue, and that's where the bacteria is growing. The red tissue then is inflamed, and it's where the toxins are doing their work on the healthy tissue to kill it, and then that way the bacteria can spread. And this has a smell like rotting chicken. It's horrid. You will smell it before you get to the room. Sometimes gas gangrene can be treated in a hyperbaric chamber. Sometimes it can be caught very, very early and be treated with antibiotics. But usually the thing that we have to do is amputate. If it is not treated, then 40% of the people infected will die. We have to debride the dead tissue, administer antitoxins and antibiotics, and as I said before, sometimes amputation has to take place. How can it be prevented? Well, if you get a boo-boo, clean it and take care of it. Let's take a break, and then we'll come back and talk about viral diseases. So most of the viral diseases are going to be systemic, but we can see signs and symptoms of the viral disease in the skin. So we think about herpes. There's herpes type 1 and type 2. Human herpes virus type 1 and 2. This used to be called herpes simplex, and I may fall back into that habit because that's the way I learned it. But basically, it causes lesions to form on the skin. Herpes type 1 we find mainly above the waist. Think of them as canker sores. And herpes type 2 is often referred to as herpes below the belt because oftentimes that is seen with genital herpes. So the lesions are going to be painful. What happens is that the viruses infect the cells. They cause the cells to fuse together, called a syncytia, and then the cells will die and release the viruses. We went over this when we talked about viruses. Here we go, an oral herpes lesion. What's a common name for oral herpes lesions? Do you write that down in your notes? Got it? Fever blisters. There you go. Owie. What we see is that in a herpes virus is that the virus enters in through a wound in the skin, sexual intercourse, being kissed by someone who has an active fever blister, and it's going to make its way into the nervous system. And so it can lie inactive in the nervous system for weeks, days, months, years. But depending on where the virus winds up in your nervous system tells you a lot about where you're going to see it expressed. So it can live in the trigeminal and then travel down the maxillary branch and the mandibular branch, and you have fever blisters on the lips. One thing you don't want is ocular herpes because that will blind you. If this is spread by sexual intercourse, you get genital herpes, and they're going to hide out in the sacral ganglia. And if you get some kind of wound on a finger, this is what we call whitlows, and we see this often in dentists. Not so much anymore because they wear lots of gloves now instead of just using their hands. They wear gloves. But a patient who had fever blisters, the beginning or the end of a fever blister, and they accidentally bit the dentist, or somehow a wound came up on the finger, then the virus got transferred to the dentist or the dental hygienist, and it will basically hide in the brachial ganglia. What's going to cause this virus to be expressed? Usually stress. We get stressed out. You've probably noticed if you have canker sores in your mouth or fever blisters, you start to get stressed out, or maybe you get one or the other before you get another viral infection. If we look at herpes virus 1, notice that 90% are going to be cold sores, fever blisters, or canker sores inside the mouth, whereas HHV2, 85% of the genital herpes cases are from HHV2. Mode of transmission, yeah, don't let people touch you. Location of the lesions, you can see there, it's basically where what's connected to where they are latent. Notice other complications. Poor babies get neonatal herpes. This is not good. They get exposed by, great Aunt Sophie kissing them while she has an active fever blister, or in the case of HHV2, they're exposed when they come through the birth canal. What an awful way to start life. So, it spreads between the mucous membrane of the mouth and the genitals. These are infections in adults, are not life-threatening, but if a neonatal child is exposed, it could be fatal. Mainly we see the characteristic lesions and say, oh, look, you have a fever blister. Stay away from me. Chemotherapeutic drugs can help control. We've got some over-the-counter stuff that helps. But once again, it's a virus, so it's not going to be easy to treat. Thought you might like to know about warts. This is a papillomavirus that causes warts. There is another papillomavirus called human papillomavirus, and it is responsible for cervical cancer. We'll talk more about that when we get to the chapter on reproduction. Most warts are harmless, but they can spread. There are some great over-the-counter treatments. There's also, you go see your dermatologist and he'll freeze it off or cut it off or something like that. Okay, direct contact, fomites. What is not spread by direct contact or fomites? Yeah, you can infect yourself in different areas. So let's take a break before we talk about measles. Let's talk about measles. Measles are not our friends. So we have rubella and rubeola. Rubella, we see a mild rash, and usually children are the ones who get it. We do have a vaccine against this, so it's not necessary for anyone to ever have rubella. Adults can develop arthritis and encephalitis. Encephalitis is inflammation of the brain, basically. And then if this is contracted in utero, so if the baby's infected while it's still in the uterus, it can cause birth defects. Some can be so severe that it causes death of the fetus. Pathogens, it's the rubella virus. And it's spread through the respiratory tract, throughout the body via the blood. Of course, the immune response is going to take over. Hooray for cytotoxic T cells. And then what we see in adults is that the immune system may very well overreact and cause arthritis and encephalitis. Spread by respiratory secretions, cough, sneeze, infects only humans. It's diagnosed by the rash. And like I said before, we have a vaccine, so we really don't need to see any more of this disease. When we look here, look at from 1966, maybe 1967, we had a peak in disease. The vaccine was licensed and given to the population. And look how over the next 10 years that the number of cases dwindled down to basically nothing. And then we looked, there was a little spike in 08, but basically the number of cases per 1,000 is extremely low. We went from about 60 per 1,000 to 10, 15, big drop. This protects our pregnant women, protects the fetus. Okay, what about rubeola? Rubeola is what is normally called the measles. We have 3-day measles and 7-day measles. Rubeola can be diagnosed by looking for Koplik spots in the mouth. It can cause some really nasty disease, but usually in someone who is already immunocompromised. The virus can cause proteins to adhere and fuse so that the virus can avoid the immune system. Basically, it's a reaction of the immune response that causes the symptoms. And this can be a very deadly disease in children. Here is a picture of the Koplik spots in the mouth, usually on the cheek. Okay, so we see that rubella is known as the German measles or the 3-day measles. Rubeola can be known as the red measles. Sometimes it's also known as the 7-day measles. You can see that which viruses cause the disease. Who are the primary patients? Notice it's children. In rubella, we can see birth defects, and that can kill a baby. The skin rash is mild, and there are no Koplik spots. In rubeola, we can see complications, pneumonia, encephalitis, and subacute sclerosing panencephalitis. That doesn't sound good. The skin rash is extensive, and there are Koplik spots in the mouth. So in rubeola, it's highly contagious, spread by respiratory drops, cough, cough, sneeze, sneeze. Again, humans are the only host, and we have a vaccine. Yay! The MMR vaccine is going to protect against measles, mumps, and rubella. So, red measles, notice that somewhere around 1966, a vaccine was introduced to the population. Notice that in the late 50s, almost 800 cases per thousand, or 800,000 cases. They introduced the vaccine. I remember getting shot up with this, and look how the disease just disappeared. And we went through several years where there were extremely few cases. Mycoses of the hair and nails and skin. A mycoses is an infection caused by fungus among us. Ooh, fungi. They are not fun guys when they're living on us. These are opportunistic. They're classified based on where they're found. Superficial on the outer surface, cutaneous occurs in the skin, subcutaneous occurs in the hypodermis and the muscles, and then systemic affects the nervous system, the circulatory system, the kidneys, the lungs. Yeah, not good. So superficial, mainly it's going to be on the hair, the nails, and the outer skin. You know, you stop and think about nail fungus. On the outer layer of the skin, you can see hypo or hyperpigmented patches of scaly skin. And this is versicolor. That doesn't look good. He does have a really good tan. Superficial, once again, they're going to produce an enzyme called keratinase. This breaks down the keratin, and so you're losing your barrier in the keratinized squamous epithelial cells. Don't share brushes or combs or, yeah. Why does it occur most often in adolescents? Let's think about this. They drink after each other. They share their hairbrushes. They share their combs. They share everything. Don't share. Don't share. Because, yeah, you get diseases. What we see with this is under a UV lamp, the infected skin will be a green color. Ooh. So, this can be treated with topical antifungus among us drugs or with antifungal oral drugs. Cutaneous, mainly you've seen some of this, and there are a lot of different manifestations. They're caused by dermatophytes, and you will recognize ringworm. It is not a worm, it's a fungus among us, and you can get it from any fuzzy little mammal. Okay. Ooh, athlete's foot. Nasty, nasty, nasty. Fungus in the toes. And, you know, you can treat that with over-the-counter antifungal drugs. It usually works really well. That's a really bad case. Icky. So most of these dermatophytes belong to Tinea. Tinea pedis is going to be athlete's foot. Tinea crucis, jock itch, not fun. Tinea unguium on the toenails. Tinea corporis, be all over the body. And then that could include the beard, which is Tinea barbae. So Tinea capitis. So here we're going to have fungus growing on the outside of the hair shafts, on the inside of the hair shaft, and it forms a crust on the scalp. Ugh. So, basically, wash. Okay? Just wash. Right? So microsporum, trichophyton, and epidermophyton floxosum. Just, yeah, nasty. They can be contagious, and they're classified as whether they're associated with humans, animals, or soil. Diagnosis? Ugh. What you see is what you get. Potassium hydroxide can be used to help if you take a scraping, it'll help you diagnose the fungus. And quite simply, you can use over-the-counter I wish they were tropical, topical agents. And if it becomes systemic, we have to use oral drugs. Icky. All right, so what if you get a fungus in a wound? Yuck. If it doesn't become systemic, it'll grow into the epidermis and produce a skin lesion. Ugh.